preparation all done. So we're getting this on YouTube. And it's going. Preparation all done. So so that is fantastic. Good evening, everyone, Medical Mondays family. So hopefully we'll continue to get better with time. And while we're not waiting, we're going to be starting and have people join us. I am Dr. Toyin of Westomi. I'm a family practitioner, HIV specialist, and I treat substance use disorder in Maryland. I enjoy coming here every Monday night to come learn and also to do my best in, imparting what I know to our communities. Tonight, we have something new and amazing. I am so excited because I have so many questions on this new and cutting edge, I won't call it treatment. I'll call it intervention in various aspects of medicine. We have our very own Dr. Oluyemisi Famuyiwa, our fertility specialist, here tonight to, start the talk on platelet-rich plasma, infertility first, and then we'll be bringing our own special guest who I've already warned, after 5 minutes, is no more a guest, it becomes family of Medical Mondays with Dr. O. So without much ado, I'm going to yield the floor to Dr. Oluyemisi Famuyiwa. We're in for a treat tonight. You have the floor.
Thank you so much. I am so happy to be here and I always look forward to this forum. Like you said, it's almost like family. Thank you. So this is a very, very exciting topic that I was researching. And while I was doing my research, I got the rep from EmCyte reach out to me on LinkedIn. And I'm like, whoa, the universe must have sent you a language because I've been researching for the past couple of months. And then one thing led to the other. I initiated it. And then he brought Dr. Everts, who's the chief scientific officer. And I told him about Medical Mondays. And then he said, well, I'd like to be on it. And so here we are. So I'm going to start by going, my part is going to be in 3 parts. I'm going to just give you a taste of what my understanding of PRP is, and hopefully start to shed some light on some of the curiosities you have. Then I'm going to focus on PRP for what I do, which is in the ovary, to give you some of the recent articles coming out, as well as the uterus. And when I'm done with that, I'll talk about what patients might benefit for it. And then I'm going to yield the floor to Dr. Everts. Okay, so let me go to slideshow. And I'm going to share my screen. So share. Can you see my screen? You see the slides, Dr. O?
Yes.
Okay.
You may want to, how do you say it? To slideshow, do slideshow.
Yeah, that's what I was going to do.
Yeah.
And from beginning, yeah.
Yeah.
And you know what? I may decide to, I'm going to unshare for a second and then reshare because it wants to share the one that just progresses the slides. So I'm going to go back to sharing. Sorry, I know I'm not an expert. I always bungle this part of it, but I'll get it. Now, what do you see?
Fantastic. Yeah.
What do you see? Just the entire slide, right?
The entire slide. This
excellent.
is
excellent. Okay, so I'm going to start with talking about see, I'm trying to back up on this slide and let's go from the beginning. Slideshow from the beginning. Ah, there we are. So my name is Dr. Famuyiwa, and I am the medical director of Montgomery Fertility Center. And Dr. Everts will be coming up after me. So I briefly talked about what the goal of tonight is. We really want you to have an in-depth understanding of what platelet-rich plasma is and why it works. And then we're going to talk about its application in the various fields of medicine. So what is platelet-rich plasma? We all know that when you draw blood and you spin it down, it's going to separate to a yellow part on top, which is the plasma, right? And then the red blood cells will come in the bottom. And that's because the red blood cells are heavier. So when you spin it through the force of gravity, those will come to the bottom. Now, this plasma up here is just plasma, period. Everything that's not red blood cells. It's really not platelet rich. The difference, and if you do this, you only spin it once, you get up to 1x, 1.6x of what your platelet count is. Now, if you look at scientific studies, in order to qualify as platelet rich, you need to try and get up to about 4 or 5x. So if you're only doing one spin, you're not really doing platelet rich plasma. And tonight, Dr. Everts is going to go into detail of how their system can separate the platelets better. And it also uses a large volume collection, so you're not collecting in a vacutainer, which we'll talk about why that's not a good idea. You actually, for this preparation, for my purposes, in the ovary, we actually need about 60 cc's of blood drawn up into a plastic syringe, and it's put into this device that I kind of squished it, but it's a little bigger than that. And we separate out the first plasma from the blood. And you can see a picture of that plasma being sucked out, leaving the blood behind. Then the thing is, you now respin this top by putting it at the bottom of this device, and you put it back in here. And the whole idea is to respin it. So now when you spin it a second time, you get a buffy coat way down at the bottom. It's just a very tiny layer. That's where the platelet-rich plasma is, right? And it actually exceeds the recommended 4 to 5x, the technique they use. They get up to 6 to 9, even maybe 10x. So it is that bottom layer that we now aspirate really most of the second spin of the plasma from and get it all the way down. I don't know if you can see there's a red layer way at the bottom of this. Okay, that's where the platelet-rich plasma is. And we now resuspend that thin area in just a little bit of plasma and then aspirate that layer through a special tunnel in the device. That is what we now use when we inject into patients in the ovary. It's different. So I'm not going to steal Dr. Everts' thunder, but I'm sure he's going to go into more detail on why this is actually purer. So why does it work anyway? What's the big hype? Well, guess what? Platelets have certain growth factors in them. They're called platelet-derived growth factors. And then there are other growth factors. They're sort of like your body's repair mechanism, except you're concentrating all the defenses into a very tiny layer. And if you will, this platelet can help with wound healing and repair. And they participate in 3 phases of this process. I believe the literature, states that also they have certain growth factors. One of them, of course, is angiogenic growth factor, angiopoietin. We can go into the exact details of the growth factors later. But several of them actually help to promote development of new blood vessels. Now, if you develop blood vessels and you have new blood vessels going into the cortex of the ovary, you can oxygenate that ovary better. You can remove oxidative waste better. And that's one of the reasons why it may actually have a bountiful effect in able to recruit whatever eggs you may have left in the ovary and also help them divide better. We know that your egg really, think about this apple, has until it's ovulated, has a full complement of DNA. You got to split it into half, right? And pair it with the other half from sperm to make a whole new human being. That splitting process is not very fluid or functional as you get older, right? So then you get a lot of disruptions. And it is believed that platelet-rich plasma helps that division, that first stage of reduction division, we call it meiosis 1, helps it go a lot better so you have less ability to have genetic accidents or aneuploid, if you will. So I just wanted to summarize a few studies before I hand it over to Dr. Everts. So I've been looking at several studies, and I'm not going to go over all of them. This is one that was more recent, and it was written by authors from Yale, from Thomas Jefferson. And by the way, one of my mentors was the author. So when I saw this article, I'm like, if he's put his name on this paper, I know it's got to be good. I'm biased, I'm sorry. Anyway, and of course, the studies were done. It was done mostly in Turkey, but then you have these authors here. And they looked at 510 women. Most of the studies before have been very, very small. And they used women with poor ovarian response, meaning women that if I give medication to, I'm lucky if I get one egg out of. And they injected them with platelet-rich plasma in their ovary, and then watched them over time to see what happens. And they found that in these women, their AMH levels were able to go up. They were able to recruit more antral follicles, and they had higher number of eggs collected, and more of those eggs were mature. Now, when we say mature eggs, really what we're talking about is the ability of the egg to complete the first phase of meiosis 1 when it breaks its DNA from 46 into 23. That's a challenge. And more of the patients in the PRP group were able to accomplish that. As a result, they had a higher amount of improved embryo quality, and those embryos were able to implant better, and there was an increase in the clinical pregnancy rate in those group of patients. Now, this just goes into the technicality. We can go into it more detail if you want. It's the same study, and they looked at ongoing pregnancy rate of 20.5% versus where they had almost like nil, and a sustained pregnancy rate of about 13%. Some of these women were also able to even get pregnant on their own without any intervention forward. So the limitations of the study include the fact that it was retrospective. So yes, you could argue that more prospective studies may help to validate this initial findings. Some of the studies that have been out there that have claimed no difference or no difference at all in outcome, when you go back and read the technique, that's what I do. I don't read the summary or the conclusion. I go into the materials and method. And when you look at it, most of them were done with devices that only spun this plasma once. So I could argue they weren't really getting the right concentration of plasma. Then the effect of the uterus on the uterus. There are several studies that looked at what happens when you give this in women who have very thin lining. And that one of the reasons I was interested in this, I have a patient whose lining is so thin because she's had numerous surgery for fibroids, and her lining has been stripped off. And I really was telling her, you need to go get a surrogate. There's nothing more I can do. Or women who they have a thick lining, but no matter what you do, and you put a normal embryo after normal embryo after normal embryo, they still don't get pregnant. And they found out that in these particular patients, when they infused the uterus with platelet-rich plasma and left it in place for like 20 to 30 minutes, within 3 days, some percentage of these women actually had an increase in their thickness of the lining, and the ones who already had a thick lining had a higher amount of implantation and pregnancy. Now, one of the studies I put it up here, and I put the article here for anyone who wants to go look at it. This was actually a meta-analysis where they looked through like 2,672 studies, and they gave very, very narrow definition of what they were looking for, and were able to narrow it down to 7 studies. From these 7 studies, they looked at data from 625 patients, roughly split almost half and half, right? And some of them looked at what I talked about, the thin lining. The other looked about people with normal lining who just couldn't get pregnant. And what they found out was the odds ratio of chemical pregnancy increased. Now, if you have to look at the p-value you don't want to, if you want to get into statistics, anything with an odds ratio that doesn't cross 1 is significant, or just look at the p-value. That's highly significant. The clinical pregnancy rate was also significantly higher, and the implantation rate was higher from patients in control. Where they saw no difference was in women who had miscarriage. They all had, equal amounts of miscarriage. But they found out that there was a significant increase in thickness of the lining. So what does it, this just summarizing improved pregnancy, improved implantation rate. I think going forward, people could argue, okay, I'll be the devil's advocate, that instead of a meta-analysis, you could design a randomized controlled trial in the future. And I know Dr. Everts is going to get into this. The problem with doing it with PRP uses your own plasma, right? So you're going to have some variability from individual to individual. That's why it's called a biologic. And in that regard, it gets difficult to say you're going to do a randomized control study. So just to round it up, what I do is try to define who do I think needs to go for PRP. I don't think it's for everybody, but I think with the right selection of patients, we may help someone. Maybe they have premature ovarian failure, or they're losing their eggs early, they're still 38, 39, 40. It may offer them an option before they say, okay, I'm going to go to donor egg. And in some patients, like my one patient, it may be the difference between me telling her, look, you really need to go get a surrogate versus trying this. As we all know, surrogacy can be extremely expensive. The unique thing I'll just throw out there with PRP, you have to tell your patients, they cannot be taking aspirin or non-steroidal anti-inflammatory agents for like a week to 2 weeks prior to, and at least, a month, 3 weeks to 4 weeks after. Why? Because those specifically deactivate and knock off your platelets. So we want the platelets to work, and you give them an anti-platelet agent, you're negating what you're trying to do. So with that, I'm going to yield to Dr. Everts to continue.
Thank you so very much. So before I bring Dr. Evans on, I just want to say to our audience that PRP is platelet-rich plasma, and it is obtained from you. So your blood is drawn, it is pinned down, and, a component of it, that one that is lighter, that Dr. Famuyiwa showed, is the plasma. And, spinning it twice, makes it platelet-rich. It becomes richer. It's actually, she said, the platelet-rich plasma. That second spin made it that. I want you to remember that, because it was going to be important later after Dr. Everts' presentation, and, for questions. This is exciting. This is new and cutting edge. We've been doing it, but this is very exciting. Okay, so I have to contain myself, so I can introduce Dr. Everts. I'm going to bring Dr. Peter Everts on. He started his career in regenerative and biological technologies in 1989 in Netherlands. He created the first in-hospital autologous biological therapy department to serve patients in cardiac, orthopedic, reconstructive, cosmetic, surgical, and vascular, surgical, and wound care procedures. That's a mouthful, but that's a lot, covers everything basically. And he started the first in-hospital one. In 2007, he received his PhD in medicine, awarded by the University of Utrecht, right?
Yes.
In the Netherlands. In 2011, he initiated the concept of advanced biological wound care combined with hyperbaric medicine using platelet-rich plasma and mesenchymal stem cell therapies in patients with diverse chronic, non-healing, and radiation wounds. In 2017, he moved to the US. Aren't we blessed? You know, bringing this wealth of knowledge to the US. And now on Medical Mondays, he moved to the US to and for the next phase in his career, as he is acting chief scientific officer of EmCyte Corporation and program director of Gulf Coast Biologics Research and Educational Center. In 2022, he was appointed as international professor at the Frontiers Health Program of the Faculty of Medicine of the Max Planck University Center in Indaiatuba, Sao Paulo, Brazil. Currently, he focuses on biological formulations, dosing strategies, and real-world data programming to establish biological guidelines, in particular in musculoskeletal and infertility treatments. Dr. Everts is an internationally recognized educator, scientist, and contributor in many regenerative medicine applications. He serves as reviewer for many journals and has published over 80 peer-reviewed articles and book chapters. So I'm going to yield the floor to Dr. Everts, and you are no more a guest. Welcome.
Thank you so much, Dr. O, for your very, very nice introduction. I feel very honored to be on Medical Mondays. Dr. Famuyiwa, thank you so much for the connection last week. I know it was all last minute work, but I hope I can well share some of my knowledge with you, Dr. O, and your audience. Let me see where we are. So you can see my screen, I guess, right?
Yes.
Yeah,
Yes.
you see one slide
Yeah.
or two slides? You see one slide?
Yes, exploring platelet-rich plasma, PRP,
Perfect.
fertility.
Perfect.
Yeah.
So this works. Oh, perfect. So yeah, I had a very nice informal conversation last week with Dr. Famuyiwa, and we were discussing her ambition in sharing some of her experience in the world of regenerative medicine, and we had a lengthy discussion, well, not discussion, chat, and so, well, listen, if I can help you anyway with Medical Mondays coming up, I'm more than happy to do it. And well, this is my title, Exploring PRP and Infertility, but I just want to make you aware, this is just a very brief introduction. I call it the helicopter view with some focus on OB/GYN biologics and touch a little bit more on infertility. These are my disclosures, as nicely managed and mentioned by Dr. O, so I'm not going to go in there. As you can imagine, I started in 1980s, and well, this roller coaster is my experience in regenerative medicine. And it's not yet done. I feel very lucky to be in the front of where we are right now. So when I get started, I started in orthopedic surgery and cardiac surgery, bringing it to surgical fields, moved to chronic wound care, using different biologics, whether it was PRP, whether it was adipose tissue or bone marrow stem cells. My PhD, we had some great publications done with highly citations, and my nomination as a professor. So why do I show you this slide? Not only to tell you who I am, what my experience is, but I want you to have a feeling that this is not an experimental therapy. The use of platelet-rich plasma therapies and other biological therapies, so from your own blood, from your own bone marrow, from your own fat tissue, has been moving forward in healthcare for more than 4 decades right now. So in other words, if you feel for the first time exposed to PRP, then please forget about the fact, well, Dr. O, Dr. Famuyiwa, we are talking voodoo medicine here. That's absolutely not the case. We built a solid foundation using PRP biologics. And where are we right now? Where are we? When we look at the treatment options, then we're all aware of, well, the surgical side of things, the use of medicine, but also since, well, over 3 decades, let's be modest here, the use of biological medicine in urology and OB/GYN, looking at a different angle, not only by surgical activities, not only by giving drugs to patients, but thinking from a different perspective, using the patient's own tissues, using blood to make PRP, use some bone marrow fluid to make a bone marrow stem cell product. In other words, when we think about surgery and drugs and the alternative of what we call interventional therapies, those therapies could be an area where surgery and drugs, well, would not make any contribution in healthcare treatment options for patients. These therapies are safe. They are from the patient themselves. That's why we call them autologous. The PRP is FDA compliant. And the beauty of it is you can make this a very personal experience. So when you speak with your patient, when the patient has questions, you can make this the patient's own therapy using the patient's own tissue, so to speak. And with all the, well, technology we have available, whether it's ultrasound, whether it's laparoscopic procedures, we can do a precise delivery of the biologics where they need to be without, well, major surgical interventions. And like Dr. Ho mentioned, one of my objectives from the last couple of years is it's all perfect to use PRP, which you see as a sample on the left-hand side, or adipose tissue, which we're not going to address now, but I just want to bring it as an alternative to PRP, also very, well, very feasible in your field of medicine. When you use biological products in patients, and we'll go over a list of indications in a minute, what we need to do is we need to validate what we are doing, and we need to keep track of our outcomes of our patients. Because for the last 40 years, and I have to apologize for the scientific community, we are still not able to come up with a classification system for PRP. We have no standards in place for preparation because people have different views. Patients have questions. These questions, well, are sometimes difficultly answered by their providers. So long story short, many institutions try to make this a very reproducible side of biological care, but they fail. And with the indications increasing almost, well, every 6 months, it's going to be pretty difficult as well. So as you can see here, I just threw out some procedures, certain fields of medicine where PRP has been used during the last 4 decades. And for tonight's objective, you see the marked box, sexual wellness, urology, gynecology, and fertility. Those have been relatively new compared to the wound care field and the cardiothoracic, orthopedic, and maxillofacial surgery. So we're only talking here maybe 4 to 6 years now that we start to build very rapidly, I have to say, information and data as well, how, in this case, PRP biological therapies can be used in these field of medicine. And the secret is the platelet. I call it the platelet secretome. And in a second, I'll explain to you why this is such a very attractive cell to consider from a patient perspective and from a physician's perspective. And this paper you see on my roller coaster, at some stage in time, we felt it was necessary to come and to present and speak to the therapy, because there were so many stories, it was incomplete, and we thought that based on the information, the literature we had available, we need to address the variety of therapeutic options and consequences for patients with this paper. So the paper has been cited over 500 times, 25,000 downloads. So it really fulfilled the need in a market to come up with clear data on PRP technology. So how does it work? Very quickly. As we sit and we listen here, I hope you're not doing anything else that might cause an injury to you, but as we sit and watch the Zoom webinar, your platelets are in a resting state, as you can see on the left-hand side. Nothing is going to happen. They float in the blood, and all of a sudden, due to triggers, to particular injuries, platelets become activated, and that's where they develop these so-called pseudopods. And the pseudopods are no more than tentacles where platelets can connect with each other, and that's where they form what we call a so-called platelet plug. So when there is an injury, they form that platelet plug, and the next thing that's going to happen is they're going to release everything that's in these platelets. And what's getting out of there are, among other things, are platelet growth factors. And on this portion of the slide, what you see is you see cell membrane, and you see on top of the cell membrane there are cell membrane we call receptors, and they're very specific for specific growth factors. And in order to reach the inner of the cell, to have cell signaling and cell communication, each of these receptors, they need to find a dedicated growth factors. So in other words, you need to find a dedicated dancing partner. That's what it is. I mean, you only can dance successfully if you have the right partner. And the same for growth factors. Particular growth factors meet particular receptors, and then they signal into the cell. And from that signaling perspective is ultimately where your repetition of exposure of platelet constituents to cells start to build new tissue and create immune modulation. And in this slide, they're just the most known growth factors that indeed are inside on what you see on the bottom, the white thin layer of gray, like Dr. Famuyiwa showed you as well. That's where the concentration of growth factors are. And depending on how you prepare your PRP and what kind of cells you want to have additionally in there, you can also have, of course, white blood cells in there, which in a lot of cases are more helpful than hurtful. So long story short, there are so many cellular constituents in platelets, from what we call the dense granules to the alpha granules to lysosomes, adhesion molecules. So it's too simplistic to think that a platelet only brings growth factors to the table, as you can see them here, because when they are empty, and this is a study I did in 2006, I believe, with an electron microscope, showing that when platelets become activated, they do release everything that's in there. So when we look up here into the purple circle, this is one platelet. Within that circle, there's one platelet, and you see all these different colorizations from granules. Those are different kind of granules. And each of these granules, each of these storage units within the platelet has different molecules, different cytokines. And as you can imagine, the Lord gave us platelets to heal, right? So it's underestimating to me that we only think we have platelets and growth factors. No, we have a ton of constituents there spread out over each of the platelet in its entirety. And when the platelets become activated, as you see down here, everything is gone. So from all these cellular structures of the platelet, when they become activated, they're released to the environment in an attempt to start what we call the healing cascade. And this is what we know from the classical healing cascade, right? So at the beginning, platelets play a key role, and then we follow a certain sequence of healing phases from hemostasis, created clots, to stop bleeding, to inflammation, cell proliferation, and remodeling. And this is just a simple picture to illustrate, well, when I cut my finger and the platelets become activated. So from their original shape, they will recognize there is interruption of the skin, the blood vessel might be punctured, releasing substances, platelets become activated, and then they release their content. And they form what we call the platelet plug. And that's the starting point for healing, because anything that happens from a trauma perspective to a regenerative perspective, it all starts with the initial platelet plug and the liberation of the entire granules that we discussed just a minute ago, and then supported by other white blood cells during all these phases of healing. Ultimately, well, the wound will heal. There will only be a scar left. So that's how platelets really work. And what has been underestimated is, well, and also the contribution of platelets with regard to angiogenesis is, well, is there more to it than only growth factors? Is there more of a significant pathway of healing that we don't talk about because either we don't understand it or we're not aware of it? But by itself, platelets have many what we call pro-angiogenic and anti-angiogenic substances that build new blood vessels. And especially in tissue rejuvenation procedures like injections in the ovaries, it's very important that we have a normal or close to normal vascularity in place. And the platelet is going to help you tremendously. When we look at the list of what kind of substances in platelets contribute to angiogenesis, then that's a huge amount. I'll challenge you to find this paper. It's open access, where we clearly and slowly really make clear how the relationship with platelets and other, blood-borne constituents like many white blood cells, how they, synergistically work together in order to restore the microvasculature, because that's so much needed in there. So just to summarize this portion, what are the powers? What are the powers, the potentials of PRP? And they are huge. Well, we discussed angiogenesis, but ultimately due to angiogenesis, so immune modulation, if the local microenvironment has some immune compromised conditions or even pain, when we jointly use PRP and we are able to activate it, or the patient will activate it by itself, which in most of the cases happening, with the addition of particular white blood cells, you will be able to accomplish functional restoration. And when I mean functional restoration, that would mean that when you look here at the bottom of the device that was shown earlier, you see a very nice layer. It's more like, an area where all the cells are highly concentrated present, right? And that would mean on top of them are the platelets, and then you see particular white blood cells that are key in, inflammatory processes, but also in tissue repair. And then depending on how you formulate your PRP, you can add or eliminate for a great portion the neutrophils. That's another distinct difference with this system. So when we look at, let's say this little box here, what's in there, then we see high density of platelets. We see particular white blood cells. And what these cells are capable of when they have been administered, when they've been injected, when they have been filled in the uterine cavity, they will promote the activity of stem cells. They will enhance the functional particular proteases that are present in that area. And the other cells, they work jointly with the platelets in clearing the environment, tissue debris, and well, at the end of the day, after all these different healing cascade processes, we see as well a lot of fibroblast activity by the production of various collagen formulation. So that really prompted to a significant amount of medical fields using PRP formulations, whether it's in musculoskeletal, whether it's in urogyn, infertility, sexual wellness, even aesthetics and orthopedics, very profoundly. But the big difference is we need to understand what your formulation looks like, because that ultimately is going to make a difference, because there is a huge overlap of the activity of platelet growth factors and platelet cytokines in folliculogenesis, when follicles need to develop in an adequate range. We already see that there is a significant amount of platelet-related growth factors that contribute to the entire phase of follicle growth. And that's where there is a very nice connection with what I call the non-surgical procedures. This is just a simple list as what you can find in the literature for endometrial receptivity. Different techniques have been used and published, looking at ovarian rejuvenation, stress urinary incontinence, pelvic floor pain, a lot of female wellness issues that are being treated with PRP technology, and recently as well with the addition of mesenchymal stem cell therapies, mainly from adipose tissue. So they're starting to develop a nice consensus, so to speak, and nice data on both the non-surgical and what I call the biosurgical usage of platelet-rich plasma products in a variety of indications, which we're not going to discuss. This is just a simple slide indicating how much has been published with very promising results. And like Dr. Famuyiwa mentioned earlier, I also wholeheartedly support the fact, do not read the title, do not read the abstract. Make sure you understand what the methods were that have been using, because then ultimately you will understand that you really can have either poor outcomes or great outcomes, like these two recent papers really indicate. Because at the end of the day, you want to be successful, right? You want to be successful for your patients. You want to work with biological formulations that make a clinical significant difference for your patients, and you don't want to be confused. You don't want to be perplexed about results or perplexed about no results. We jointly, as scientists, as practitioners, we need to come up with the recipe book, right? And that recipe book is going to be all dependent on what kind of product you're going to use, because the product market space is completely out of control. 40 different companies, 40 different products on the market, and I even don't bother anymore to discuss it. But what I want you to take away is, as a physician, but also as a patient, simply ask, what kind of PRP are you going to give to me? Because not every PRP is born equally. They are not the same. None of these products all demonstrate positive outcomes. And what's key, what we learned in other medical fields, but also already in the young history of infertility, is that the dose really matters. So if you have time, do your research, ask the right questions on what's going to be important, because there are many studies out there that really do not create any positive results. And test tubes are not PRP preparation. Test tubes have been developed for laboratory purposes to do an analysis what's in the test tube. They never have been designed to be present in PRP preparations. And we tried to show that. We did an extensive proteomic analysis with Stanford University, looking what's the difference. What do we have in a plasma type PRP, so to speak, and in a truly committed PRP sample. And these differences were stunningly different, as you can imagine, where PRP really outperformed any of these plasma type devices. And this is actually the difference. So with these plasma 2 PRP devices, you will, in a ratio perspective, deliver 2, and the ratio with a true PRP device is more than 10. So the ratio itself is completely different, and it has been confirmed by this very nice study that dose really matters. So if you want to have thin endometrium and if you want to increase it, then the number of platelets, the formulation that's needed really matters tremendously. So slowly getting to my last couple of slides. Again, the world of Uro, OB/GYN, biological medicine is very, very exciting. You will have options that you do not have or that patients do not have compared to the use of medicine or surgical procedures. And the list you see here, what are the pathways that we can influence with your own biological product, whether it's blood-borne, blood-based, or mesenchymal stem cell-based with fat. These are all typical healthcare pathways that we can generate and that we're going to be able to modulate. But it's very important, again, to understand exactly what you are doing. And I do understand that for a lot of physicians who have been in the medical space for many, many years, the knowledge as where we are right now is not up to speed because there is no education, there's no training available that really brings young physicians to the level where we discuss the living systems and the ability to use in patients, not from a surgical perspective, not from a medicinal perspective, but from a biological perspective. So that's something that we and organizations and educational training programs need to really understand. And last but not least, please stick to the facts. Again, those facts are going to be very, very important. And this is a paper I highly can recommend for my friends in Europe and London. They did a very nice review on well, the potential of PRP in the female reproductive system. And they came with some, well, great and very solid recommendations on, well, the positive use of PRP in female reproductive pathologies. So last but not least, to summarize, patient outcomes can be enhanced by the implementation of autologous biological preparations that are capable of producing platelet numbers that are, well, in the basis, ready to, well, regenerate, rejuvenate, or repair tissues. The literature is exponentially growing in your field of medicine. And like was mentioned earlier, I'm not a fond believer of randomized controlled trials with the use of biologics due to its variability. What I do believe in is in real-world data. Because if you want to have a positive outcome from a published randomized controlled trial, in order for you to have the similar results, you need to follow the same inclusion and exclusion criteria. So in other words, if you're going to include all your patients, you will not have the same outcome as a randomized controlled trial because you want to help patients. You don't want to say you're not a good candidate because of X, Y, and Z factors. So we started to look at real world data following treatments in MSK knee pathologies. We have a very small but very effective real world data collection system in infertility going at the moment. And these data really help us shape the next future in protocols and in the optimization of methods in order to have consistent patient outcomes. And I do understand there is a learning curve, but the learning curve for non-surgical based on where we are, how we are organized with key opinion leaders with educational purposes, that can be avoided. And for me, the laser sharp focus needs to be on a team training and education in order to achieve clinical significant outcome. Thank you so much for the opportunity. I would like to leave it here. I could speak for a couple of hours, but I want to stick to the respectful time frame. Thank you, Dr. Famuyiwa.
Thank you so much. Wow. You know, I told you I have a barrage of questions. This is exciting. You said it. You said the Lord gave us platelets to heal. And at another time, you said it's not voodoo medicine.
Yeah.
I love that. I use PRP in knees for arthritis. And my mother was an example of somebody who, received PRP treatment, and she never had pain in her knee again. And this was pinned once, Dr. Famuyiwa. So if we did it twice, she probably would never have needed that cane that I insisted she has to use when she's going out of the house, because she navigated okay in the house, but I was, concerned. I still wanted her to use the cane when she goes out. But PRP worked like magic. And she passed at 94 and never complained about knee pain again. So I have experienced PRP. And now we just had presented tonight this cutting edge in the ovaries. And so, Dr. Famuyiwa, to reiterate, you thinking that even though we've been saying that start to use your own eggs, is at age 45, women may now have the opportunity to be able to go beyond that age and be able to still have, eggs that would do what it's supposed to do and have their own babies, right?
Well, I mean, I think the data is still coming in. I'm not so sure that I'll go much past 45, but before 45, there are so many women who have premature ovarian failure, even in their 30s, that this may actually help. And then you have a lot of, I joke, my average patient age group is actually about 41, 42. So in any given day, I see about 4 or 5 new patients in that category of women. And in the past, a lot of those may not be able to produce eggs. And when you do get the eggs may be of such poor quality that you really can't do much with it. So this might actually give them a second chance.
But it is important, though, to pick the right place to go. Absolutely. And pick the right company.
I think so. I think there's a lot of people are doing Google research, and because they don't know where to turn to. And you really need to know this information. I don't know where you can find it. But if someone says they're doing platelet-rich injection, as Dr. Everts says, you really want to know what kind are they giving you, because they're all touting platelet-rich plasma. You really don't know which kind they're using. And there have been some big hospitals in New York that said, oh, well, we found no difference and blah, blah, blah. And then when I went and looked at their technique, they were using one that was a single spin. So I wonder if they could go back to their data, go back to their patient population and say, can we get our hands on a formulation that's actually very rich in platelet? And if you do further digging, you'll see there might be some presentations where they'll compare 3 separate machines. And then they run the platelets. When they spin it down, they'll send it to like a lab court. So do us a favor, count the platelets. It was incredible. The difference is phenomenal. You're talking in the order of billions, right? 8, 9, 10 billions of platelets concentrated. There's a huge difference. And if you're going to go for something like this, you want to know how do they do it, right? What are they using?
So if there are patients here in the audience, the questions to ask if a physician wants to sell you PRP. First question is, what kind of PRP are you going to give me? And then, well, you could expect an answer. I'll give you, platelets, of course, or the answer could be, I'll give you platelets and some white blood cells. So if they make a story about I'm going to give you platelets and they forget about anything else, you need to be cautious. And the next very important question is, what is the average concentration of platelets that you're going to give to me? Let's not speak from layman's to dosing, because that's a whole different discussion. But if the guideline would be at least 1 million platelets per microliter, so 1 billion per milliliter, that gives us a fair assumption on what kind of technology the selling physician is going to use to you as a patient. And there's a, well, clinical accepted concentration of platelets, what we call clinical PRP, and clinical PRP should meet at least 1 million platelets per microliter or 1 billion per milliliter. So if a patient is asking that to his physician and wants to use it, and he says, I have no idea, that to me personally would be a reason to say, let me rethink what I want to do. And if anything is significantly below that number, you most likely will be treated with a product that's, well, not capable of inducing a clinical significant result. Why can I say that very confidently is we reviewed the literature and we published it in the angiogenesis paper. We were looking for what is the formulation that has been used, what is the dose of platelets that has been given. And all of these, well, negative clinical results, they were all related to the composition, but mainly to the concentration of platelets that were given. But these two simple questions can give you an idea whether it's worth your money to spend for PRP technology, because up to now it's out of pocket pay anyway, right? So the physician should be able to give the patient a fair chance for a, well, positive therapeutic approach.
So that being said, you know, this is now used for hair growth.
Yeah.
And it works like magic. I learned today, we were having discussion about this today, and my student in clinic told me that instead of Botox, which causes a lot of complications, PRP is now being used, you know, under the eyes, you know, on the face, and it is your platelets producing great results. But one of the take-homes that we have to have tonight is that you have to still be with the right company to be able to get it from the right company. The physician you work with has to get it from the right company in order for you to get excellent results. I want to ask you, what makes your company different? Is it that centrifuge, or you actually, what is it that sets you apart from the ones that do the single spin? Just for our audience to understand it. And what's the name of your company? We want to know. So that, I mean, if I'm going to a doctor, I might as well say, if you get it from so-so company, I'll do it. But if not, I'm not. As simple as that.
Yeah, the company is called EmCyte Corporation. It's out of Fort Myers, Florida.
Dr. Famuyiwa, can you put that in the chat box for me, please?
Oh, sure. It's
Okay,
sure. I'll get it's.
Yeah. Sorry about that, Dr. Everts.
No, that's fine. So the company is
So-
EmCyte Corporation out of Fort Myers, Florida. What sets EmCyte apart from its competitors? Well, several things that we consider very important. First of all, it's a long history of the company in the field of regenerative medicine. The product Dr. Famuyiwa is using is a 4th generation PRP device in the history of the company. Some other companies have their 1st generation, maybe a 2nd. And why do we have already the 4th generation PRP device? It's not only because the other ones weren't working, but the field is changing. Keep in mind, we started this business, like I showed you on my roller coaster, in a surgical setting. And in a surgical setting, you have different objectives for using biological therapies than in a non-surgical setting. So the devices that were initially used in the surgical setting had a completely different outlook, but also different goals to achieve. So when we move from surgical to non-surgical to interventional medicine, so to speak, all of a sudden we had different demands. And one of them was, okay, we need to be able to make different formulations. We need to make different formulations, but in order to do so, we need to have higher volumes to work with. As you can imagine, test tube devices, 10 mLs, and if you want 5 mLs of PRP, that concentration number is not going to be very high. So in order to come up with the demand, the changing field of regenerative medicine, interventional medicine, that prompted the company and its owner, Patrick Penny, to develop continuously PRP devices based on the current status of the market, including with the data that have been produced in that market space, to always be able to come with different products. And it doesn't mean that single spin devices cannot be great devices. We have a single spin device, but there's a difference in well, the effectivity of the device, of course, the design of the device. So two spin devices will have a different preparation profile from products than a single spin. And if you forget about our company and look at other companies, yeah, then the difference between a single spin and a double spin is going to be even more profound, so to speak. Last but not least, what we learned over time is you can produce the most beautiful device on the market to use PRP, but if you don't know how to apply it or how to manufacture it, you still have an average device. So in other words, what we appreciate and what we learned over time is we need to support our products as well with sufficient educational goals and opportunities for physicians. But that's where Gulf Coast Biologics was developed as a second company under the same roof as EmCyte Corporation to teach physicians and other practitioners how to make the ideal biologics, how to work with the different formulations, but also how to deliver it, right? And that's where we feel we have a strong entity, including laboratory facilities to validate. So that really puts us aside, maybe a little lengthy in my explanation, but that puts us aside from different companies.
Thank you so much. This is so exciting.
I only want to warn you with your PRP for your face, make sure what your goals are. I tell physicians always, what are your goals? What is it you would like to achieve, whether it's in musculoskeletal, whether it's in facial aesthetics, whether it's in infertility, you need to have your goals ready. And just on a side note, and we can discuss it another time, I would love to, is if you want to get rid of wrinkles, a good formulation of PRP will work. If you're going to use PRP as a filler, it will fail after 2 to 4 weeks because the biological activity of the body will take care of everything and will start fibrinolysis, and the clot will be gone that is used to make a filler. So there are so many side angles we can discuss, but to be very specific and to be very effective in your goals, make sure you know exactly what it is you would like to treat, and then base your biological therapies accordingly.
So I have hands raised, and I hold my questions, you know, but I'm struggling with holding my questions. So Dr. Ajagbe, kindly unmute and ask your question. That's Dr. Ajagbe.
Hello. Can you hear me?
Yes.
Yeah.
Hey, Dr. Everts, thank you so much for the presentation. Excellent. With my own experience with PRP in dentistry, we were using it for bone augmentation and dental implants. And I think one of the reasons why there was very little success was because the separation of the buffy coat from the spin was not very finely tuned. Because most of the time, by the time you try to separate the buffy coat into try to get the best layer of platelets, you actually have dilutions. You have a whole lot of contamination with other stuff. So I agree with you in the sense that you do need, we need, in fact, if I can find the best setup, is something I would like to use again. I got so discouraged after spending so much and not getting as desired results that I said, well, PRP theoretically works, but something is not right in the way that we actually separate the platelet-rich plasma that we really need.
Come over.
And so when I see, before the program started, we started talking a little bit about that. And I think this is very technique sensitive, and anyone who wants to take advantage of this has to really know how the technique is. And the centrifuge tube is very, very important. If you cannot separate the layers that you really need cleanly, then it's going to be very useless. You will do all kinds of things and still not get the same desired result. And I agree also with you that the goal must be clear. What do you really want to accomplish in the use of the intervention, the biologics? What do you want to accomplish? In my own case, I want to see excellent bone growth and what we call osseointegration with the implants that we place inside the jawbone. So if you want to explain that a little bit, how I know we're talking about reproductive areas today, but if you can just throw a little bit of light on how it can be applied to other areas. I know you probably mentioned it along the way, but if you can indulge me in this, I just want to know if your system is something I can go back to and evaluate for my own use. Thank you very much.
Thank you for your nice comment, and I'm happy to hear that you agree with me on some of the aspects I put forward. Maxillofacial surgery, dental work was actually one of the first where PRP has been used successfully. But the differences started to occur when more companies came to the market with 10 mils of blood, spin it, take some kind of a PRP product, and then do funny things with it. It's not only the company, it's not only the tube that makes a difference. What's very important, what I learned over years, starting in the surgical field, work with orthopedics and bone grafting, is we need to appreciate and we need to understand that there are also limits, and especially with bone building cells, what they like and what they don't like. I made a mistake, for example, in the early 1990s with the spinal fusion operation, that we thought the more platelets we had, we did the best job we could. That was absolutely wrong. That was not the case. So especially with bone, there are two things very important. With bone, it's important that you have white blood cells next to your PRP, because bone will grow if there are neutrophils in the area. If there are no neutrophils there, then the bone growing activity is to a minimum. But also the dose, the concentration, anything above 5 times the native baseline value will create more osteoclastic effects. So the balance between osteoblast and osteoclast is very, very narrow, and exceeding a particular concentration of platelets, a number of platelets in a bony environment, will actually have the opposite effect. So the formulation is important. Make sure it's a leukocyte-rich formulation, and then don't go over a concentration of 5 times, but have at least above 3 times the baseline. Those are the takeaways if you want to do bone grafting. And then the other one is, what's the ratio between PRP and whatever it is, whether it's bone chips or whether it's bio-os, how you mix it, what's the ratio between the liquid part and the solid part in order will create a mature bone graft. So there's a whole different discussion. I'm happy to have a separate discussion. I'll give you in a second on the chat side my email, my phone number. And those of you who have questions about any particular indications, please reach out, because if you don't reach out, I can't help you, right? But I'm happy to share my experience in that area. And like I said, each of these different, well, arenas for biologics, they have their very specifics, which you will not always find in the literature.
Thank you.
Thank you so much. Please, while, as soon as you have time, if you please put that in the chat box, because I'm sure, some of our people will want to contact you directly. So I have Dr. Booker. Dr. Booker, kindly unmute and ask your question.
Thank you very much for this presentation, Dr. Famuyiwa and Dr. Everts. I actually, as a comment, I had PRP for my partially ruptured Achilles tendon. And that was about 5 years ago. And it worked, because if not, I would have had to carry the boot for another 3 months. But I don't know the formulation now. I don't know. So I'm now learning something. Thank you very much. But it worked. Now, I wanted to know, if you're having it, when you contact the company, do they send a special machine, or how does that work? How do you know what products to use for special procedures?
Yeah, that's a question, Dr. Booker. We get quite a bit of time. Well, first of all, one of the distributors who has set this up is available here, who could help you with setting up a centrifuge. And then the company will support the distributors with educational programs. That can be done through Zoom. That can also be done in person. And most of the time we start with a Zoom meeting, make sure everything is on site of the where the physician is. And then if the request is, I feel more comfortable, get to my office, and we spend the day in the office. We do a couple of patients together, and we show you the things that are not, well, easily readable in the literature or in instructions for use. So we keep very close with our local distributors in your area, or who you would like to work with. And then with the company and with the distributor, we make up our training and education programs based on your patient population.
Thank you.
Thank you so much. So in the chat box, I just posted, our very own fertility specialist, Dr. Oluyemisi Famuyiwa, she's right on point. You know her. She gets results, and this is cutting edge. If you need to contact her, I just put her contact in the chat box, our office and phone number. So I have some questions in the chat box that I want to now, revert to. Sister Yomide said she would like to know the applications of PRP in diminished ovarian reserve due to damage to ovaries resulting from endometriosis. From a patient perspective, what are the questions to ask to ensure you're getting optimal benefit from this biologic? Which of you want to answer that? Dr. Famuyiwa, give it a shot.
Okay, I'll give it a shot, and then I'll let Dr. Everts present more cutting-edge information. I think he showed you how platelets, when they activate and split up and create the pseudopods, part of it also is to try to clean up the mess that endometriosis leaves behind. Endometriosis is, I'm sure he probably has more data on it, but it's a very debilitating disease. I think that it depends on the extent of the endometriosis. And if you have bulk endometriosis, that can be reduced to minimal, and then engage platelet-rich plasma may be beneficial. But I'll probably say Dr. Everts probably has more articles on that than I do.
Yeah, there was one slide, and I'm pretty much past your brain too quickly. I'll put it in the chat box as a reference, and that's a paper from 2021 called Ovarian Rejuvenation Using Platelet-Rich Plasma. And they came up with, with great numbers, and they were lasting for up to 12 months after a single procedure. So I'll put those references in there, read them, go over it. And I also state what Dr. Famuyiwa and I mentioned, that the dose is really important. And that was stated, again, not by a company, but independent researchers, indicating the effect of diminished ovarian reserve based on, the function and the development of eggs. So I'm happy to send that reference.
Thank you. Is there a limit for how many rounds of PRP one can do or have after 45 years of age?
Like we just mentioned, it really depends on what is it that you're injecting. The same for knee osteoarthritis. You can do one injection and you're good to go for a year, or you can do 4 injections, you're good to go for a year. So it all gets back to, how profoundly can you rejuvenate the ovaries? How profoundly is the dose in respect to follicle growth and the number of follicles? So the true answer is, I don't know, to be honest. But what we know from the literature is that, long-lasting effects have been seen with the proper dose of PRP.
I think one of the doctors that does the most in the US, he does every 3 months. But then again, like Dr. Everts says, you wonder what kind of PRP is he using. You understand? But when you give the PRP, at least in the few patients I've done, you might see an effect in the month after. So and I did actually see a response within the first cycle, and it's set to increase with the second and third month. But I guess when you start to see a decrease in response, you could redose it. Remember, it's your own platelets, right? So it's like, how much of your own blood can you get? It's your own.
That is true.
Right.
That is true. So I have a patient who is struggling with fertility, and she has actually done PRP before, but it wasn't effective. So what would you suggest based on your newfound knowledge with EmCyte and, this double spinning?
So one of the things that, and actually we make it sound simple, but it's not easy to inject an unstimulated ovary. It's small, right? And you want the eggs are mostly located in what we call the cortex, meaning close to the surface, right? So you can get the most result if you give multiple injection around that cortex. But it's not as easy as you think, because you might think, okay, I'll use the smallest needle I can find, so I can really needle, most of the cortex. And I tried different needles. If you go to a really super skinny needle, which theory says would work better, the needle just bends. It just buckles, right? So then I settled on somewhere between my regular standard 17 gauge needle, which is very firm, and between the 22 and 21 that kept buckling. And I find that I use 20, which is sort of in between, to try and traverse the ovary. So it depends on, does she have any scar tissue that has moved the ovary away from the vaginal apex, right? Such that it's very hard to get to that ovary, right? So those are the questions you want to ask. I know in one of my patients, we actually had to press down the ovary because it was so high to bring it, closer to the needle range, so that I could now go to multiple spots without buckling the needle. And there was one patient where we had very good access on one ovary and very poor access on one ovary. I mean, I gave some, but it wasn't like the second ovary that got the bulk of it. And lo and behold, most of her follicles were in the ovary that I was able to get better access. So the question is, what else is going on? Do you have a lot of scarring? How easy is your ovary to get to? What type of PRP have you been given? How old is she? All those factors come into play. Some of the study says that if you see at least one antral follicle at the beginning, those patients tend to have more of a better outcome than patients with zero antral follicle at the beginning. So I think it's a very variable answer there.
So it's patient dependent, the patient
I
needs
think
to be
so.
evaluated.
Yeah, I think so. What else is going on? How
Yeah.
much surgery has she had? What kind of scarring is going on? And you know, let me show you, like I always hold this fake ovary out here, and this thing shows that the ovary is off to the side. Your ovary is actually supposed to, it's dangling right next to the vagina, right? So I could go through the vagina, get out of the vagina, and boom, right into the ovary. Well, if your ovary is stuck here because of endometriosis or surgery, you're not getting to that ovary unless you go through the uterus, which you can't really go through the uterus with those fine needles. They'll simply buckle, right? You can't get it. I know, and this was not before, this was before I started doing PRP. I had a patient whose ovary was so high, so adherent from multiple surgery. And I simply sent her to the GYN oncologist. And I said, I need you to move that ovary, share it off where it is, and bring it down and tie it down where I can reach it. And then when we finished and she got her eggs, he was able to go back and free it up and he moved away. But at least I got what I needed.
Yeah. Wow. Thank you so much. Take home. Patient needs to be evaluated to see, you know, where they are and what needs to be done. So when she failed the PRP, it's possible that they didn't probably have good injections, or it wasn't properly prepped PRP, like we just learned. So patient needs to be reevaluated, and things need to be done specific for that patient. So I have 3 questions in one here. You ready for this? Dr. Everts?
Give it a try.
Like 3-in-1 questions.
All right, I'll make notes.
Is PRP commercially available? Was the first question. Can PRP be transported outside the US for use in patients in Nigeria? Second question. And the third question, is your equipment available commercially?
Yes, no, yes.
Yes, no, yes.
Of course,
Like that.
no, of course, it's commercially available. The company is www.emcyte.com. Gives you a lot of information. Nigeria, I'm not sure whether we have distributors in Africa. That's something I'm more than willing to look into. Yeah, and formulation
Wait a minute. You're not sure if you have what in Nigeria?
and distributors.
Ah,
Yeah, or
So-
whether it's possible to deliver direct, I have no idea.
got you.
Outside of my scope.
Yeah, so that's something we
Okay.
talk about to see, you know, if you have no distributor, then we need to get one.
Yeah.
You know,
sure.
for the country. I will chat with you on that one. So we have your phone number, your email address. Thank you. And again, Dr. Famuyiwa's information is on the platform. If you have, you know, questions or you need fertility care, please reach out. Endocrines. Oh, that's you.
Yeah, I sent some references, direct downloadable articles. So yeah, I'll add one more to it. But yeah, this is very exciting to be part of your Medical Mondays, and I do understand it might be a little bit surprising of where we are with the field of regenerative interventional biological medicine, but yeah, it's the tip of the iceberg.
So we are excited. Well, I know some of us are excited on this platform. I am definitely excited. You can see I can't contain myself. I want to go back to, you know, Dr. Ajagbe's, you know, question. You know, one of the questions he asked was to talk about other areas where, you know, PRP is being used and it's working. It's doing a great job. So in one of your slides, I actually made a note of that. You showed places, you know, the knee in orthopedic orthopedic arena, the knees being injected. You showed the eye. Can you say something about the eye? because that is important. If you can regenerate an eye that is going blind, or one that is blinded already, and
It's
can be
really macular degeneration.
Sorry?
Macular degeneration.
Macular degeneration. PRP works for that.
Oh yeah. Oh yeah.
Oh wow.
Yeah.
So if I reach out to you later, can you give me a list of doctors who are able to do that, who we know what they're doing and they know how to intervene there?
Yeah.
Because I have a couple of people that would need that. What about the hair? We're seeing, oh my gosh, do you see how many young men are losing hair these days? They just bald.
Yeah.
What's going on there? I'm not sure. But, you know, I saw the injecting of this scalp on that slide. Can you talk about that?
How much time do we have?
Uh-huh.
No, there's alopecia is very, very complex. In order to do PRP in female or male with variety of types of alopecia, I think a lot of things need to be cleared before you start to use PRP. But once a decision has been made that PRP would be a viable option for hair regrowth, or let's say waking up the hair follicles, it's going to work if, in this case, what we see the formulation is more than 1.5 million platelets per microliter with all the cells in there. And then based on the depth, how you want to inject, where you're going to inject, how many injections per square centimeter. There are so many details that will make that very successful or less successful or non-successful. But that on itself would be a, Medical Monday webinar.
You know what? I want to take you up on that. I think we need to have that, a special seminar for that. You know, if anyone who wants to chime in the chat box and you think, I'm right, please support me on that.
I was just saying that we were not going to get through this tonight. Didn't I tell you that?
You did. You did. Because there are so many areas.
Yeah, what is a nice topic is a combination of facial and hair aesthetics. And then eventually, that's a nice discussion that you could do in the same 60 minutes as we're doing right now. So that would be great.
So that's another topic.
And I'm sure, Dr. O, we could even elaborate. You know how many people have diabetic-related blindness?
I know.
Yeah.
So that is very important. We need to talk about eye. There's so much going on about eyes. And in my head, what I keep hearing in my head is rejuvenation. Rejuvenation. And that is huge. And it is your own plasma. It's not like you get it, because there are commercially sold plasmas. You know that.
Yeah, but it's not autologous, right? That was your name.
Yeah, and they don't always work. Some of them are dead before they get to you.
Yeah, but it's also illegal to do.
It's not illegal to do?
It's illegal to do.
Really? But I heard people are doing it.
Of course.
It's illegal. Oh, wow.
Yeah. So from the regulatory perspective, is a completely different animal on other things than autologous PRP. That's what we call it, autologous. I mean, birth-like product, exosomes, all these fancy new names on that roller coaster of activities. A lot of them are not allowed in the US or even outside of the US. They're illegal. FDA is hunting you down if you use it.
It makes sense for it to be illegal because that's somebody else's plasma. What else do they have? Do they have HIV? Well, maybe HIV will be dead, but what about hepatitis B, C? What else is in that blood that, you don't know? You're absolutely right.
So we talk about autologous, freshly prepared at point of care, same day, returning back to the patient. Not putting any umbilical cord, scrape the cells out of it, sterilize it, wash it, put it in a vial, and then we think there are still living cells in there. What's the purpose of sterilization?
Mm. Mm.
Yeah.
So we're going to have another session on alopecia. Dr. Motosho just wrote on the platform that, yeah, we should have another session on alopecia, blindness, diabetes. It's agreed with us, Dr. Famuyiwa. This is fantastic. So,
Yeah, and the other thing with diabetes, if I may, is consider, well, the huge increase, which we have no answer yet, is in patients with chronic complex wounds, including diabetic wounds. How nicely can be treated at point of care in a, well, let's say day clinic, using biologics to heal these wounds instead of, well, ultimately amputations and disability and mortality.
I have a patient who can actually benefit from this. I'll talk to you about that, from the wounds. So this is a question here. How does it work? How does it work for men's reproduction and prostate area? Any take on any researches, any use in that area? That's erectile function.
Yeah, erectile dysfunction is treated very, very successfully, including Peyronie's disease. Again, the secret is in the, well, the application technique, so to speak, in combination with the bioformulation of the products being injected. Great papers have been published, less great papers have been published because they didn't know what they were doing. But for, well, erectile dysfunction, it works pretty well. Even now, PRP is being used in the lab as a medium, so to speak, for spermatogenesis. So yeah, that area is under full development.
For spermatogenesis. So
yeah,
no sperm count.
Yeah.
Whoa, can be increased. This is fantastic.
Yeah.
So is there any indication for use of PRP in oncology?
No, because PRP has a lot of vascular endothelial growth factors. We know that VEGF is very profound growth factor also in angiogenesis as a carcinogenic, well, potential, so to speak. So if cancer is in the area, we'll stay away from it for at least 6 months after a cancer therapy, surgical, chemo, radiation, when there is absolutely no remaining cancer cells left, because there is a, well, chance, a theoretical chance that, well, if there are cancer cells left and we use PRP, it will provoke, well, again, cancer growth.
Yeah, because it has growth factor in it.
Yeah.
Yeah, and that's why it will grow here. So, does this work for osteoarthritis of old age?
Now listen, who's asking that question? What's an old age?
Like
What's old?
120.
What's that?
I said like 120.
Yeah, that's old. Well, it's more like what stage of osteoarthritis is it? The grading system, right? Is it 1, 2, 3, or 4? Are there any other pathology involved, like meniscal tears? Is it bone marrow edema? But in general, osteoarthritis on an older age, above 65, will still work with the proper dose, and sufficient papers have been published about it. A single injection, and I'm not 65, but I've had a couple, and I'm good for a year to go after I had my initial injection done. I follow up with a maintenance dose, because the same like diabetes, right? You stick to the medication for the rest of your life. The same with osteoarthritis. We're not changing the synovium, right? We're not changing the cartilage, but we can change the local microenvironment for up to a year, so patients are free of complaints.
So like 63 is what it's saying. So how does this compare to stem cell? That's another subject, right?
Yeah, it's another subject. Well, keep in mind, stem cells are more profound because anything out of a stem cell product is also in PRP because they both originally from the bone marrow. But the added value of a bone marrow concentrate, so to speak, instead of a platelet concentrate, is the addition of mesenchymal stem cells and progenitor cells to have a more profound effect. Especially in, well, let's say more advanced osteoarthritis, or you can do the combination of PRP and bone marrow. That's what we do quite a bit, actually.
Yeah, I think, I'm just thinking my mom got the PRP and stem cell, and it was only once.
Yeah.
And that was like 5 years before she actually passed at 94 and never had pain again. So it worked. So any other questions? None. I don't see any there. Did I miss anything, Dr. Everts?
No, I don't think so. You covered it all. We have one supporting the discussion on alopecia. That's good. So we have 3 now. That's fine.
Yeah. I don't think I missed any.
No.
Fantastic. Man, this has been fantastic. Thank you so, so much. Yes, I'm seeing over there, people are saying, thank you. This was very informative. Thank you, thank you so much. We appreciate you too. We appreciate the audience. So,
Sorry, I'm driving, I can't type.
yes, go ahead. Go ahead, Madam VP. That's our Madam VP from California. Go ahead.
No, it's scary good. I mean, all the information. So, but we have to get you into Nigeria. The yes, no, yes, it's not enough. It needs to be yes, yes, yes.
Don't worry. I'm going to get him. We'll fix that. Nigeria is the next place to go. We'll fix it.
All right. Thanks, Dr.
Thank you so much, man. Thank you. So, and, I'm glad Madam VP came on because this month makes 3 years that we started Medical Mondays every Monday. And it's been awesome. We learned so much on this platform. And the people who make Medical Mondays are the Medical Mondays family, people who show up. So we were talking about, okay, last week we gave a gift to, I still need to get it to them, a blanket to a couple who have missed Medical Mondays only once in the 3 years. And they are phenomenal. They are also the couple who helps me a lot in the back end, to stream this on Facebook. I stream it on YouTube. They work out all the technical difficulties and they hear all the time. So this week, who do we give gift to? There are so many people who participate. And I started going through the list of people who participate every week. And I'm like, oh my gosh, it's a lot. I need help. So I think maybe I'll wait till the end of the month and, collate the list and, but stay tuned for the people we're going to just recognize for being faithful families and great contributors on Medical Mondays. Dr. Veronica is going to help me with that. And she had agreed to do that. So stay tuned for that.
So I'm going to vote for Dr. Ajagbe. It needs to be monetary gift so that we can share it.
And you too. I vote for you. So.
Okay. We're bringing actual beef for that.
That'll work. So that being said, stay tuned so that we're going to have fun, figuring out how we do this and what gifts we give. So I'm going to now defer to Dr. Famuyiwa to give us our closing words. And then Dr. Everts, please stay put so that you can give us the grant.
So thank you so much. I mean, this is exciting. You know, I'm always trying to dig up new information. I've actually been doing this research for a while. It wasn't like overnight for me. Yes, I was able to rapidly scale and implement it, but that's because I've had series of months actually of studying, and it became so clear to me that something real was going on. And I remember one of my mentors who said, whenever something new comes out in medicine, now you don't have to be the first, but don't be the last. You know, and I'm glad I waited, because all the initial centrifuges that came out were all these earlier centrifuges that we now know are not nearly as effective, especially where it comes to the ovary. So I'm glad I did my thorough research, and it was just coincidence that led me up to speak with Pete, and then one thing led to the other, and connecting with Dr. Everts, and I hope to continue my collaboration with them, because I'm always excited to learn more and to present more data, and hopefully we'll be able to do some collaborative research together.
That'd be fantastic. And what you've done actually in the 2 weeks just so totally blew me off the water. And by the way, this was not our topic for tonight. She was the speaker for tonight. Yes, that has been set, golly, in the beginning of the year or something. But you know, we had a different topic in mind. She had a different topic in mind, and then you know, she found Dr. Everts and just got so excited and said, I have to talk about PRP. This is what I want to talk about. And, you know, got me excited too. Thank you so much for this knowledge shared, that you didn't keep it. You care so much about our community all the time to come out and share this with us. We appreciate it. Thank you. Thank you. So, Dr. Everts?
Yes. Well, first of all, again, thank you so much for becoming part of your family. I feel really honored to make an appearance on Medical Mondays. Thanks to Dr. Famuyiwa. I've had a long career and I'm not yet done, because there's so much to do and so much to learn. And you always think it's, some getting older age, right? About your legacies. And one thing I'm very happy about is my focus is on transferring knowledge. I just do not want physicians to make mistakes that I and my fellows made years ago or even very recent. The only way to move forward in regenerative medicine, whether it's in facial aesthetics, whether it's in infertility, whether it's in other gynecology disorders, is share knowledge. And sometimes that's good and some good information, sometimes it's bad information. But as long as we learn something from it, because I always have been working with a lot of pleasure with patients in the first place, and second with physicians. And if that synergy is there between a pathological patient condition, the physician, and that biological mindset, I always tell physicians, if you do not have a biological mindset, that is fine. But if you want to develop it, we're going to achieve in, creating regenerative medicine for your practice and for your patients. If it's only for the money that you're involved, because it's out of pocket cash, it's not going to work. You will have failures, you will have disappointing patients, you will have very upset peers. So sharing knowledge, be part of a community doing the right way, be accessible for questions. That's my mission for the next couple of years. And like earlier mentioned, if at some stage more physicians would like to join on techniques for infertility, we definitely need to have a separate discussion in seeing, how can we collect data? Because ultimately the future for young physicians is, this is what I do, and this is what I achieve with my technologies. So that's perfectly fine with us. That's completely in our wheelhouse, what we have been doing for the last 20 years. I'd like to leave it there. Thank you so much.
Thank you. Thank you so very much. Thank you. I appreciate it. Thank you. I private chatted you, so look at it. I don't know if you saw it. And there are lots of thanks on the platform. They said, thank you, Dr. Famuyiwa, for putting everlasting smiles and joy in families. Dr. Peter, you are special. Dr. Everts, thank you. And Auntie Susan, see, she's showing her face right there. She's the one who wrote, thank you very much to both Doctors Famuyiwa and Everts. Highly informative and interesting. Pray for future success to both the givers and receivers of biologicals. Thank you. Thank you for a great talk on the innovative indications for this. Thanks a million, our great doctors. Thank you very much. Another home run on Dr. Who Mondays. Thank you. And, thank you, Dr. Veronica, for this, for, sending me this. Please, everyone, remember our doctor in Nigeria, Dr. Faduile, running for governor in Ondo State. Zell me $100. So we put it together and send it to him, just $100. If each of us put in $100, guess what? We've taken care of his primaries. Primaries is coming up. It's primaries is when? It's in a few weeks. So let's support our doctor. Let's put our people in there so that they can take care of the populace. Nigeria needs help. Primaries is April 11. Oh my gosh. It's just a few weeks. We need to send this like within 24, 48 hours so we can help him. We need help in Nigeria. We need help. And this is our man in Ondo State, a physician, pathologist, right on point. You met him. So you have my phone number, Dr. V. Did you post it, Dr. Veronica? Shy. I didn't post it. She's private chatting me. And I didn't, I kept seeing it. I thought it was on the platform.
Doctor, I thought I was posting it on the chat. Let me put it.
No, you're not. And I'm
putting it on you. I'll get it out now. I'm going to post it for everybody.
I don't do well with stuff like this. Okay.
No, sorry, let me put.
Thank you. So thank you so much, everyone. If you have other questions, we're always available. I'll make sure I get it to Dr. Everts. Any further questions? If you don't get it to him, he has his email address posted there and his phone number on the platform. I'm going to repost. Jeez, is it so far back? Yeah.